Morning, everyone. Thank you for the opportunity to be here, and thank you to the organizers for the invitation. My topic, a battle between fact and conviction, 10 minutes. Probably enough time to discuss the recent successes of the South African rugby team. Probably too much time, really. But quite a short time for abdominal compartment syndrome. So what I'm going to do is take you on a whirlwind tour of where we've been and where we're going to, and hopefully a few things in between that you'll enjoy. These are my disclosures, no industry disclosures to make. That's my city, Pietermaritzburg. I work at Edendale Hospital, 900-bed hospital. We serve 1.4 million people. I'm the only intensivist in the hospital. So this is a story to start off with, and I wanted to grab your attention. So when we talk about the Seekers, not these Seekers, this is an Australian folk band apparently called the Seekers, but these Seekers, this is Dorothy Martin. Dorothy Martin was a housewife in the early 1950s. She started getting mind messages from an extraterrestrial group that lived on the planet Clarion. Amazing. And she started this group called the Seekers because they were told about a fault line running through America that was going to crack America open, was going to get swallowed into the sea. But fortunately, the aliens, they liked Dorothy, and they decided to send a UFO to save the Seekers because they believed in Clarion. Now, what's interesting is Leon Festinger, a psychologist, and some of his colleagues, they infiltrated this group and waited on the eve of this event to see what was going to happen. To quote someone famous, this was going to be huge. So what happened? 20th of December 1954, they gathered in Dorothy's house, and 12 o'clock came, and the UFO didn't arrive. Okay, but remember, when you're waiting for a UFO, synchronize your watches. And as someone pointed out, the watches were all fast. So in fact, there were 5 minutes still to go. So they waited another 5 minutes, and after those 5 minutes, nothing happened. Okay, so now they were in disarray. They were expecting the UFO, it didn't arrive. Fortunately, at 4 o'clock, Dorothy received a second message from the aliens. This time the aliens said that because they believed so strongly in the prophecy, the Earth had not cracked open, and that is why the UFO turned around and went back to Clarion. Now, Leon Festinger wanted to see what was going to happen. Surely the prophecy didn't come true. They would all drop their beliefs. But no. In fact, it motivated them even more. And he developed this concept called motivated reasoning. We see it now called cognitive dissonance, when fact starts fighting people's convictions. We see it with climate change. We see it with the anti-vaccine group. We've even seen it in medicine. We've seen it with intravenous fluid therapy in the last few years. Do we see it in abdominal compartment syndrome? So why abdominal compartment syndrome? Well, it's common. The incidence of acute kidney injury is up to 40%. You can see there that the incidence collective data from 2004 to 2017 shows that the incidence can be very high, sometimes even more than acute kidney injury. And abdominal compartment syndrome is particularly high in conditions such as burns and pancreatitis. But not only is it common, it has consequences. And thank you to Annika for this data. It's unpublished. It's going to come out probably beginning of next year. A multi-center randomized trial looking at 500 patients. Part of the trial was to look at the epidemiology and the incidence, and you can see there that the incidence of intra-abdominal hypertension on admission was a third of patients coming to ICU, and up to 50% would develop intra-abdominal hypertension during their stay. What's more interesting, though, is that as the severity of the intra-abdominal hypertension increases, so 90-day mortality increases as well. So it has consequences, but fortunately it's easy to monitor. We monitor the intra-abdominal pressure via the bladder, and some data that we've recently published looking at correlation between different methods of intra-abdominal pressure monitoring shows that we can actually use intragastric pressure as well as intravesical pressure. The correlation between those two and direct intraperitoneal pressure is actually very good, particularly when the pressure is elevated. So, what about the physiology? Can we better study this? Definitely. We've developed models now where we can mimic a mechanical intestinal obstruction in animal models, and we can actually study the physiological responses. There's a nice CT scan showing that intra-abdominal hypertension and compartment syndrome that's been induced in a pig. Polycompartment syndrome is a concept which is now 10 years old, but we need to take notice of this because as the pressure rises in the abdomen, it starts affecting all the systems in our body, particularly cardiorespiratory, but also our immunological, and I'll get to that in a moment. All the systems are involved, as I mentioned before. Again, this is data which we're going to publish later on this year, and you can see that all the systems are involved with different pressures And of course, this is a porcine model, and I know you guys don't treat pigs, although sometimes you might feel like you do. We don't treat pigs, but we can't ethically do this to human beings. So we can see here that a lot of these systems are involved. The green signifies significance, and you can see that all the systems are involved. Lastly, just to mention that the abdominal compartment is probably more important than we previously thought. There's a lot of data being published now on the human microbiome. You can see here 2017, already over 7,000 articles. And the human microbiome, its major home is, it's all over our body obviously, but its major home is in the intra-abdominal compartment. So when we're influencing the intra-abdominal compartment, do we influence the human microbiome? Of course we do, and I'll get to that in a moment later. So, how are we doing around the world with abdominal compartment syndrome? In 2007, we ran an international survey, and what did we find? Well, 85% of people were aware of the condition, 28% were aware of the society called the World Abdominal Compartment Society, and overall knowledge scores were relatively low. We repeated that survey this year. What did we find? Well, awareness had increased for both the society and the condition, but knowledge scores remained low. Not only that, but 18% of people around the world were not measuring intra-abdominal pressure. And 44% weren't aware that the guidelines on how best to manage this were revised 4 years ago. So not doing too well. Let's have a look at a data summary now from the last 2 years, 162 papers in English. Epidemiologically, what do we know at the moment? Well, we know that it affects adults, and we know that it affects pediatrics as well. Morbidity and mortality is high, prevalence is high, awareness is low. It affects common things that we see every day: burns, pancreatitis, medical, surgical patients. And measurement should become part of our basic monitoring for these patients. The majority of cases are seen on admission to ICU, and the worse the severity, the worse the stay, the longer the stay, the worse the outcome. When it comes to measuring this pressure, we know you only need to do one reading, 1 ml per kg for babies less than 4.5 kilograms. You can use nasogastric tubes in babies and adults. Can't use femoral venous pressure, it's not that useful, and D-lactate might be a useful marker for intestinal ischemia. Clinically, which patients do we measure intra-abdominal pressure on? We still don't know exactly. We measure it on everyone, but in fact those that are high risk, abdominal surgery, those that are shocked to receive more than 3.5 liters of fluid, medical ICU patients, they should all have routine monitoring. There's actually limited evidence for some of the things that we do in our units to evacuate intra-abdominal contents, like nasogastric tubes and prokinetics and laxatives. Theophylline decreases intra-abdominal pressure. Only one study. Non-depolarizing muscle relaxants, CVVH diuretics, these are all things that we use without much evidence. Currently, they are being researched further. Chinese medicine, purported to reduce intra-abdominal pressure, no survival benefit. Dexmedetomidine might be better than propofol, and epidurals might be better than morphine when we manage patients with intra-abdominal pressure, surprisingly. And body positioning, yes, we know we should lie the patients flat, but those are only from 7 observational studies. What about outcomes? Keep the pressures low if possible when you're using a Bogota bag, and I know that you probably use vac dressings now on abdomens, but in the developing world we still use Bogota bags, and high pressures actually have a detrimental outcome. Here we go again, the human microbiome. When we increase the intra-abdominal pressure, we increase bacterial lung translocation. Patients get pneumonia when the intra-abdominal pressure goes up. This is cutting-edge stuff. And intra-abdominal associated damage in every organ, I've mentioned that already. So, the future, we need to quantify which patients are most at risk, because at the moment, we're recommending measurements in all patients. We need to look at some new therapies coming out, and particularly those targeting the melatonin receptors seem to be interesting in decreasing the inflammatory response in the intra-abdominal compartment. We need to attenuate this pathophysiology, and we need to protect the microbiome because it has immunological consequences. And maybe in the future, we're going to be treating the bugs on our bodies as opposed to treating our bodies. And we've got to come up with a more sexy name than poo pills. So, time for change. Yes, education. We need to utilize this organization called ACCCCN and the resources they offer. We need to improve undergraduate curriculum and increase postgraduate awareness. This is a condition which is affecting our patients that we're not even monitoring for. We should monitor 4 to 6 hourly. That should become routine in adults and pediatric critically ill patients. We can use the bladder, you can use the nasogastric tube. I don't think it makes a difference. And certainly we should include medical patients in that, not just abdominal surgical patients. We should incorporate the WSACS guidelines into our protocols in ICU that we have at the moment. Limit our fluid therapy and figure out when we should be de-resuscitating these patients and getting them to offload that fluid that's holding them back. And certainly we need to be aware of the polycompartment syndromes and the effects that it's having both on our ventilation, cardiorespiratory system, and our immunological system. In terms of research, watch the space, outcome-based, clinical risk. Those are things that are going to come out in the next year or two. Some new interventions, hopefully, and obviously the effects that the intra-abdominal pressure has on the microbiome. We need to be thinking more closely about these things. So, truth versus conviction and motivated reasoning, does it exist in this field? Does it exist in some of our practices? Does it exist when you listen to some of the talks in the next few days? Leon Festinger said, "A man with a conviction is a hard man to change. Sometimes he needs more than facts to change his practice." So I certainly hope that failure to measure the intra-abdominal pressure doesn't land up in this museum, which is the Museum of Modern Medical Mistakes. Thanks very much.